lags absolutely at rock bottom in terms of the BRIC countries. So whilst, of course, your share of government spending in healthcare is 31%, in private it's 69%, your out-of-pocket payments are the highest in the world at some 79% of that expenditure. So you don't need to be a rocket scientist or a philosopher or, dare I say it, a neurosurgeon to work out that these small numbers for such a big country are placing enormous pressure on your system. And when we conclude, I hope this afternoon, with a call for government, for providers, for trainers and for the community, I hope that our report that will be received by the Indian Prime Minister tomorrow is more than just a report. So that's enough from me anyway. First, and we've asked each of our speakers to speak for no more than 4 or 5 minutes to keep to time. Dr. Mehta saying she's 2 minutes, so that's great. We will ask her questions later on. Dr. Mehta, over to you. Thank you.
My panelist colleagues, ladies and gentlemen, at the onset, I am thankful to the organizer to give me this opportunity to be with you this evening to share my views. Health and education are the two cardinal parameters of all-round development of the society. And when it comes to medical education, these two elements get fused because it can be considered as the foundry through which the trained health manpower gets generated. I am representing Medical Council of India. It is a regulatory body, and our function is academics, ethics, and curriculum. It was in the historical city then known as Madras, Chennai. The first medical college of modern medicine opened in 1835. This was followed by another one in Goa in 1840, and thereafter in Calcutta, Bombay. Since then, the pace of growth of the medical education in India has been steady and continuous. There are currently total 2,248 medical colleges worldwide, out of which 387 or about 13.5% are in India. In fact, our country is the largest producer of trained health manpower in the world. The annual intake capacity of the MBBS course in India is over 48,000 annually. The postgraduate avenues for degrees, diplomas taken together accounts about 28,000 seats, while 917 are available for the super specialty. This means that around 29,000 medical graduates are being churned out every year. The registry which is being maintained by the Medical Council of India, about least is over 8 lakhs medical graduates are registered in our registry of Medical Council of India. The growth of the medical education in India also needs to be seen from the viewpoint of the demographic dividend. There was a time when India's population was considered a bane. However, in terms of demography, it has turned out to be a boon. In fact, as much as 52% of our population in today, they are below 25 years of age, while 72% is below the age of 35. India has the highest percentage of young people in its fold compared to any other country. And this unique demographic dividend would continue for another 25 to 30 years. This is a crucial time window for us, an opportunity to transform this youthful population into precious human intellectual resource. Medical education has two broad objectives. As Radhakrishnan has said, that higher education needs to cater for training, research, extension activities and culminate in sustainable development for the society. In pursuit of this vision, the 11th five-year plan has spelled out higher education, including medical education, shall be governed by three trinity: access, equity, and equality. Access and equity are governed by the laws derived from the Constitution. Quality in medical education, however, remains the concern of Medical Council of India. Medical Council, as I said, it is a premier regulatory body. To ensure the quality in medical education, we need regular updating of curriculum, formation of the criticalized objectives, training the trainers for desired output. Latest teaching tools and the technology have to be blended with the appropriate modes of evaluation. The Indian Medical Council Act 1956 needs to be amended by vesting the Medical Council of India with the jurisdiction and authority for accreditation of medical schools through the National Accreditation Board. Also important is evolving a national perspective development plan for the location of the medical schools all over India in the planned and the phased manner. To improve quality in education and address common concern, we need to network with the Medical Council of other countries. In terms of trained health manpower, only 4 countries in the world, Brazil, Russia, India, and China, will be able to boast of a surplus over the coming decades. India's existing educational structures makes us the most dominant player in this segment. To benefit from this opportunity, all we have to do is to evolve India's medical education in format that is fully positioned to meet the requirements of the doctors, nurses, and paramedicals. At present, the Medical Council is acting all on this front, and we are working on the changes in the curriculum and also so many other changes which is required. Having a need-based approach, we are trying for that. Thank you very much.
Thank you, Dr. Mehta. That was the shortest 2 minutes I've ever heard. Now, Dr. Mahana, over to you. And if I can keep our speakers now to 4 minutes or so we've got time for some questions and answers. Thank you very much indeed.
Thank you very much, Mr. Chairman. Good afternoon, ladies and gentlemen. It's a very great honour and a privilege to be here this afternoon. I thank Apollo for the invitation and for their generous hospitality, and to my fellow teammates on the KPMG team for putting in all the hard work in advance of this. Before I continue, can I just have a show of hands? I know the buzzer thing isn't always successful. A show of hands. How many people have seen Michelangelo's David in Florence, either a picture or a reel? Do you know that when Michelangelo won the public competition to create that fantastic, phenomenal statue, he was given a 6-meter-high block of marble, and for the first month, he walked around it. Now, the city fathers were probably slightly anxious at that moment, thinking of all the money they'd invested and when things were going to change and what was going to happen. And when they asked him, slightly nervously, "Maestro, what are you doing?" he said, "I'm looking for the statue within." And he's described the job of a sculptor as releasing statues from marble, not chipping away marble to shape it. And I would like to use my remaining 3.5 minutes to talk about releasing the learner within. My field is in faculty development, and we're here today talking about a talent pool blockage. We're talking about numbers, we're talking about educational opportunities, we're worrying about the healthcare of our population and where the leaders are going to come from. But I believe there is a sump of talent sitting in primary care that we can tap into. We heard Mr. Rajan in the last session talking about how district general hospitals can be taken up as sites of learning. In the UK, we very successfully used primary care as a site of learning. So I'm just going to talk to you a little bit about the type of teaching and learning opportunities that exist there. I believe that training in primary care is not about filling empty buckets. Our learners are sponges. They're the brightest and the best. all around the world, they can read books, they can access knowledge. It's not about filling empty buckets. It's not even about lighting fires beneath learners. I don't know about your trainees, but mine are already fired up. It's my job to stop demotivating them with the structures I put in place, the assessments I require of them, and the difficulties in the workplace. I believe, like Michelangelo, if it's not too much of a stretch, that it's about releasing the learner hidden within. Our kids are bright. Our trainees, our medical students, they've got all the resources within them. And I believe that we can tap into that, and the model for that is what's happening in primary care. The issue we've got in healthcare is that with an increase in specialization, care becomes fragmented, right? People learn more and more about smaller and smaller areas, and the patient shuttles between them. As barriers between subspecialties grow up, healthcare becomes less flexible. Systems build up that prevent people contacting healthcare. So my argument would be that generalists bring with them generalists who deal with undifferentiated, unfiltered, vague, unmedicalized symptoms get good at cutting through that. They get skilled up in being able to take a wider perspective. And those are essential teaching skills. The problem is, of course, and perhaps I would say that, wouldn't I, general practice is hard. It's a very easy specialty to do very badly in. It's a very difficult specialty to do well. As David Haslam, past president of the RCGP, said, undifferentiated patients are hard. The next patient could have schizophrenia, piles, unhappiness, or cardiac arrest, everything and anything, and in no particular order. So we need to get our trainees to be able to learn to manage that uncertainty in a safe and effective way. We need learners that can tackle problems that they can't foresee, that they don't know is coming. And which means the teacher himself needs to invent new imaginative ways to access. We need a new type of training. Eric Hoffer said that in times of change, which is where we are now, learners will inherit the world, whilst the learned will find themselves beautifully equipped to deal with a world that no longer exists. So we're looking for 4 skills. Mr. Chairman, I'm in my last minute.
Thank you.
4 skills to release the learner within, to fire up our learners to teach themselves. They need the skills of reflective practice. They need to be able to self-assess their performance without a teacher to guide them. To keep them safe in independent practice, how can they analyze from feedback and from outcomes? And they also need to link that with critical appraisal skills so they can take information from the literature for themselves. Secondly, they need to be able to place the patient, not the disease, at the center of the care pathway. This systems thinking prevents that fragmentation of care that I was mentioning before, and that's a primary care skill. Our learners need to be able to negotiate risk. They need to be able to balance needs and wants, what patients think they want and what they need, what populations need, balanced with what individual patients need. And for that, they need to develop respect for patients and empathy so they can work together as co-partners in health. And Niti is going to talk a bit more about how populations and communities can also build on that partnership. But my 4th observation about how we can develop in learners the skills of self-reflection and self-empowerment is that most of what learners need is caught, not taught. It's picked up along the way from role models, and that's where we all come in, so that we can stress-proof our juniors as they go through this period of change and this period of enormous flux, so that they can deal with the uncertainty they face. We can demonstrate our important communication skills and build them up in that way. I believe that a commitment to generalism is the way to strengthen healthcare. I believe that a commitment to teaching excellence within generalism will pay us with excellence in healthcare. Thank you very much.
Thank you very much indeed, Dr. Mohammed. I often feel that Dr. Paul needs no introduction, so without any further introduction, Dr. Paul.
Thank you, Mark. Good afternoon, everybody. I feel really privileged and honored to be here. I've spent the last 28 years in the UK NHS, being a GP, just like Kay, running a practice in a very inner city population. We serve 3 of the most deprived wards outside of London. And now I find myself in India, being Chief Medical Officer of HCL Avatars. I don't quite know how I got there, but I did, and there's some folks sitting at the back that managed to get me back here. I've had some very interesting journeys in India and in the UK, and I'm just going to share some things with you. I'm going to talk to you about the power of communities, and that's what I've been doing over a long period of time. So I sat in my general practice one day, and I looked around me, and it was the same 12 people that have been coming to see me over 15 years. And I looked around and I said, why are these people still coming to see me? And obviously, I'd done nothing in my 15 years of general practice, so they still kept coming back to see me. And that made me take a good, long, hard look at what we were doing as GPs within a community. So what we started then to do was to look at harnessing the power of communities. I'll tell you a little story about our Healthy Communities Collaborative. So in our practice, we have 45 trained volunteers that are wrapped around my practice. The story has a reason, by the way, guys. I'm not rambling off into a rabbit hole. The 45 trained volunteers that I have wrapped around the practice in the UK, 80% of that got back into work. They learned health skills, and they've gone back into work. The Department of Trade and Industry called us about a month before I was due to leave and said to me, how did you do it? And this is just about asking the question. So I didn't assume, my practice didn't assume. Don't assume what your communities want. Ask the question. Once you ask the question, you have the answers that the communities give you. So in India, coming back to India, that's what I've been attempting to do. So our clinic in Gurgaon looks very different. It behaves very differently. The people that live around it are very different. So that community needs harnessing in a very different way. In Noida, it's very different. It talks differently. It behaves differently. And that's what we're going to have to do in India. What I also see in India developing around me is the people that come for jobs. So I've just trained the first 32 doctors and nurses in HCL Avatars. And what did I find? I found doctors and nurses who were hungry for knowledge. I found doctors and nurses who don't know where to go because there are not enough postgraduate medical seats. They're coming to us to be trained to be GPs, and they're the most motivated bunch of people that I actually saw. But I also saw a competency gap. I also saw people in ambulatory care, which is the space we're in, don't have the necessary skills because all your training happens in hospitals. So the DNB program, and I saw Professor Batra here this morning, ends up training all its GPs in hospitals. Well, you can't possibly be a GP if you trained in hospital, because the first time you walk into general practice and that person walks into the door and says, I'm not feeling very well and I don't know why, and I have a headache and I have a stomachache and I have a backache, and my mother-in-law is troubling me today and I really don't know what to do. And you have to put your pen down and start all over again. You don't get taught this in hospitals. You get this taught in general practice. So the upskill and upscale is going to have to happen through the talent we have in the community. That talent is going to have to be harnessed the here and now, and Arvindam and Devi Shetty and the others have done it very well. They're innovating with people, and we have to do that in India. I have 3 healthcare assistants that I'm training at the moment, one of whom run a pulmonology lab for All India Medical Institute. He learned it by sitting outside on the bench outside. He knows how to do spirometry. Now you need to formalize these things because there's that talent out there. How are you going to formalize it? And I think we're going to have to do that pretty sharpish in India. Again, just about the harnessing of the power of the communities. Just throw a little question out, if I may, Mark. Does anybody know what's the most evidence-based intervention that reduces teenage pregnancy rates in the community? Take a flying guess, anyone? Nope. No, that didn't work. Anybody else? Anybody else? It wasn't handing out pills. It wasn't handing out condoms. It wasn't anything like that. If you increase the educational attainment of young men, it reduces teenage pregnancy rates. It's the only evidence-based intervention in the history of medicine that works. And this is about harnessing the power of communities. We really have to engage our communities in self-care, in self-regulation, in getting the skills up and going, and that's what's going to make India the new people innovator for healthcare skills. Thank you.
Very good, Niti, very good. Now, before I introduce Miss Karen Linus, who's the Managing Director of the NHS Leadership Academy, I would like you to thank Karen, either before her speech or perhaps after would be better, because Karen's just flown in for the day, and she is in charge of the biggest, boldest, bravest leadership development programme in the world, and she's about to say a little bit about it. Karen, please, over to you.
Thank you very much, Mark. That's something to live up to. That's good. Clap now before I speak. It doesn't get any better. Thank you so much for inviting me along. And as Mark says, I'm only here for the day. So I hope I say sufficient to whet your appetite so you might invite me back. I'm going to pick up on a couple of points that have been raised by previous speakers and share a little bit with what we're doing, because I'm hoping it will be of interest to you. And we're working with colleagues at KPMG to do this. Firstly, there isn't a healthcare system in the world that isn't short of talent, and indeed there isn't an industry in the world that isn't short of talent, and it is no surprise to anyone in the room, I'm sure, for you to know that we are all chasing the same people. The maths do not stack up. We will not be able to recruit the numbers to our health systems and to our industries that we need to. So my first plea is to look to those people that we already work with. Niti pointed this out about thinking more creatively about who those people are. But you will already have staff in your healthcare system. And I'm not just talking about physicians, and I'm not just talking about nurses, but every single member of staff in your organisations and every community engaged leader and every patient has the potential to make a much bigger contribution to the health of your population. And they will do that if they feel properly trained and skilled and developed, if they're working at the very boundaries of their professional capability, if they are exercising every single bit of discretionary talent that they have. So my first argument is to put investment into those people through really creative development opportunities. Lord Chris made a point, by the way, that we were preparing people by developing them for the 20th century. One of the lessons we've learned about the programme that we've commissioned is that the universities that we went to were very keen to offer us some dusty old programme that was perfectly appropriate to develop people to work exceptionally well in 1972 England. We had to work very hard with them to get them to redesign their curriculum and their delivery methodologies so that they were more fit for purpose. So training and development for every single one of your existing staff. Secondly, look to new places for talent and development, grab them and develop them too, and do this at pace and at scale. One of the challenges we've had in our development history, and this may be familiar to you, is we've gone too small. We've talked about developing very small numbers of people who at best then go back into their organisations and become exactly the same as everybody else very, very quickly. One of the secrets of the programme that we're running, I think, is that we are developing a critical mass of people so you can genuinely see change happening at scale and at pace across your organisation. So be incredibly bold with your investment decisions. And on the back of that, a number of speakers have talked about this morning, creative and very innovative use of technologies is the only way that any of this development is affordable in the way that we want it to be. Some of the online development opportunities that KPMG have designed for us move to a very different space in terms of emotional learning as well as rational learning. So we're helping people be much more emotionally literate, to be able to have difficult conversations, to be able to give difficult messages, to think about the impact of their behaviours on others, and they're doing that through online training as well as face-to-face training. So invest boldly in your existing staff, every single one of them. Don't just invest at the top of the organisation. Do it at pace and scale, because if you're going to make the difference that you want to make, you need a critical mass of people that are on board with you. And think really creatively about your new technologies. They can genuinely make a difference to those people that you can reach.
Thank you, Karen. Now, in the interests of time, Mr. Chimoy has very kindly agreed not to speak for 5 minutes, but I wonder whether you've got any reflections at the moment. Okay, now we're going to stare at the technology people, and we're going to have 2 or 3 bouts of technology, and then we're going to ask our panel to reflect on any point that they care to reflect upon. So hopefully you've all got your little electronic voting buttons. And if I can have the first question up, please. Technologists. In your own time. The first question is: the greatest barrier affecting supply of quality healthcare professionals is A, outdated curriculum. Don't tell Dr. Mehta that, please. B, regulatory stringencies. C, poor and ill-defined career prospects. Or D, lack of well-qualified faculty staff or faculty. Vote now. And just to let the technology people know, we'll be going into the second and third question as well, simultaneously. Sorry, consecutively. And you say? Oh, quite evenly split, so we are in a lot of trouble then, aren't we? So, joint first, outdated curriculum, and regulatory stringencies. We'll come to Dr. Mehta first at the end of the 3 questions. Okay, second question, please. What role should the government play in health education training? Is it A, the regulator, B, the financier, C, the training and education provider, D, the apex level program manager and coordinator, and E, all of the above apart from C? You have 15 seconds. I'm sure we all appreciate it could be one or more of these, but go along with the game. And the answer is? Regulator, financier, and program manager and coordinator. How wise the audience is. And the third question, and just to warm up the panel, and Mr. Chimoy, I'd like a few words from you, that would be excellent. We'll ask you to respond to any of these. What is the greatest challenge in giving greater autonomy in patient care to nurses or community health workers? Is it the regulations, A? B, lack of medical training for nurses or the community workforce? C, resistance from existing care professionals? Could that possibly be the case? D, issues with technology linking hubs with remote areas? And E, resistance from patients? Wow. Lack of medical training for nurses and community workforce, followed by resistance from existing care professionals. That's interesting. Reminds me of the old joke, what came first, the chicken or the egg? Now, let's have some responses from our panelists, and if it's okay, this time, just a couple of minutes each, we'll go down the line, starting with Dr. Mehta. No, would you just, any comments or reflections on the questionnaire and the survey that you've just seen? Are you surprised?
No, I'm not surprised. It's very valid questions you have asked, and alternative you have put at the end of the day, all of them.
Yes.
To be. You know, it's difficult to put your finger on one thing, because health care itself is a very elusive and a complex subject to interact with. But at the same time, it's a very, very important subject in our life to deal with it. And it is a really good thing that we are trying to deliver, or we are trying to think of a health for all. But as I said, it is a very complex, it has got so many other aspects. Like everybody, right from the morning, I've been hearing that hygiene, environment, food, nourishment. And as I mentioned before in my Senate discussion that, see, we are living in two Indias. One India is a very good India where you've got excellent hospital, very well trained people, and at par with the international level, we have been working and giving a service, offering a service, and that is a medical tourism. But the other India where you just go through books or read one articles, 7 lakhs children die because of the diarrhea, maternal mortality, and all that. So it is a contrast.
Yes.
And our aim today should be to live in one India rather than two India. And so to give my opinion only on regulations of medical council or etc., will not be enough.
Yes.
So it is a holistic approach to this problem is desired.
Yeah.
Thank you.
I mean, that's a very pertinent point, isn't it? I mean, surely the Ukraine and Russia tells us that any country that treats the same people as two separate countries reaps the consequences eventually. So I think that's a very, I think, poignant point that you make there. May I just ask you one question before we move on? Are you personally satisfied that we're training enough doctors in India?
No, enough doctors. The training needs to be changed that I mentioned. I did say I'm satisfied.
Yes.
Curriculum is old, 1956 formation was there. And the regulations we need to change. We need to have the amendments. We need to have the accreditation board of our own so that we can keep control over the outcome of doctors and all that. I didn't say I'm satisfied.
Thank you very much indeed. Dr. Mahana.
Thank you. About 20 years ago, my trainer told me a story about how she had been approached by the professor in her university teaching hospital as an intern, as a junior house officer, and asked for her career thoughts. And she said, well, you know, Prof, I'm thinking of going into general practice. Oh dear, he said, what a shame. You'll be such a loss to the medical profession. You're much better than that. Just 20 years ago, the self-esteem of general practice in the UK was very low. And nobody wanted to do it. It was seen as a default option if you weren't good enough to do anything else. One of the things that worries me is that I'm seeing something a bit similar here about family medicine. And I just wonder, as we think about self-esteem and pride in the profession, whether we shouldn't somehow be talking up generalism. It worries me when I look and hear my junior colleagues and junior trainees here that I work with in India talking about how the number of seats for DNB or for any postgraduate training doesn't match, especially in primary care, the numbers that want to do it. So people end up by default in primary care. That worries me a bit. And I mean, it's great to have the opportunity to ask you about that, if that's okay, Mr. Chair. The opportunities for postgraduate training in primary care.
I couldn't stop you if I wanted to. Do you want to answer the question, Dr. Mehta?
Yeah, we are also thinking of, as somebody has mentioned about the family practice, we have primary care, DNB, and more stress on the social or community medicine that has been under our attention, and we are trying to create that one, new courses.
Thank you very much. Karen, any reflections on the statistics that you saw from the audience? Anything grab you?
Yeah, I want to disagree enthusiastically with one of your answers on what's the biggest barrier for people taking on additional roles. With the programs that we're currently running, we're seeing something like 15,000 people engaged in a program. Not one single one of them is constrained by their own ability, their own enthusiasm, or now, because of the support they've had, their own confidence. almost all of them are constrained by somebody who is currently doing a bit of their job that they are reluctant to relinquish. I think given the shortage of certain expertise and certain skills, we have it in England, you have it in India, I think people have it all over the world. We cannot allow people in certain professions to retain a grip on elements of their role because they think nobody else is capable of doing it. A way of releasing capacity and capability in your system, exactly as it is in ours, is developing people to work at the very, very limits of their competence. And we should be encouraging them to push against the people that are constraining them to not do so.
Good point, Karen. We're glad you came. Mr. Chinoy, would you like to offer a few reflections?
Yeah, thank you, Mark. I think, I was quite interested by, first, the type of questions that were asked. And it would seem as though the healthcare sector in India is constrained by the availability of doctors, nurses, and other such highly educated people. When we were looking at the NSDC and the study that Mr. Pawar referred to in his introductory speech, we found that the bottleneck was far lower. We didn't have ward boys. We didn't have people who could actually look after hospital kitchens. We didn't have people who could look at the front office of a hospital. And there was nobody in this space who was actually looking at this space. The second thing we found is that once a doctor gets in, right, into a hospital, if there's a new robotic surgery arm introduced, right, there was no formalized way of training and certifying that doctor. The medical council didn't believe it was their jurisdiction. The other people said that they can't do it. So in one of your questions, you said barrier to career growth, because the problem was being viewed from a different kind of focus.
Yes.
So the one thing that we thought we need to address this is actually create a holistic kind of an approach to the human requirement in the healthcare sector. And then say that, okay, and this is something to look at it, what worked in the past will not work in the future. So if today we are at X doctors per thousand, or 2.38 or 0.38, which is lower than the world average and lower than the millennium goal that we need to have, yes. If we want to reach to 4 or 5 or 6, what is it that we need to do? And then the Medical Council of India should be empowered to say, in 3 years or 5 years, you've got to do this, right? And given the ability to do that. In addition, you need to actually look at the other sectors. And we were debating when this thing came up, the answer came up to what is preventing the growth of people, and we thought it will be the professionals already existing in the organization. What we found was that the maximum resistance coming to us when we wanted to set up capacity to work in this space with the existing professional organizations saying, hey, you can't do that.
Yeah.
And therefore, we need a different system. We talked about technology and the great work that you're doing in trainers. We have a shortage of trainers. But the specification is 1 teacher to 20 nurses or 40 nurses. This is what you need to do. Why can't we take the best trainer to 200 people? 3 years ago, I was talking in an audience similar to this, and I said, hey, guess what? 3 years from now, you're going to have to find an alternate to dissection, because dissection will be banned. And just 3 weeks ago, it's been announced.
Yes.
Imagine if, and we're talking of cruelty to animals, right?
Yes.
What is going to happen 3 years hence from now? Right? Michelangelo, when he did that, he actually went into the mortuary and he looked at bodies and he learned of that. But it means that we need SIMS, we need high impact, we need a different way of teaching. Technology interventions that was referred to in the keynote address is going to change the way that we are going to teach and we are going to learn.
Thank you.
And the regulatory bodies need to change with that and need to empower the employers, right? To actually do this in a different manner. And that's what you're doing in a different level, let's say in the Sector Skill Council in the UK, yes, for the healthcare sector, or in Australia.
Thank you very much indeed. And finally and briefly, Nitty, your observations on the questionnaires and the survey?
I was just gobsmacked that everybody wants the government to be the end-to-end regulator, the deliverer, the program manager, and everything. That kind of gobsmacked me, and I wondered why. Because actually what you've seen developing, and that's a huge disconnect that I see in India, because I see skills developing out here, like Arvindam and Narayana have done. I've seen them developing skills that are outstanding. You've got outcomes that are better than anywhere in the world, with skills that have been developed by people who are innovating on the ground, and then people are thinking they want the government to do that. It's a very bad idea, chaps. Don't do it, because once the government gets involved in everything, you've had it.
I won't quite end on that note. Let me end on two notes that give us, I hope the audience, and you've been a wonderful audience, and I'm sure you'll join me now in thanking the panel for being a wonderful set of panelists. But two reasons to be optimistic. As I said, I've worked in 61 countries in the last 5 years. I travel a lot. I'm going to Brazil in 3 weeks, China in 4 or 5 weeks, Russia not so often, India I come very frequently. But I just want to play a quick game, if I can, before we close. We're bang on time, you'll be pleased to know. Do you know what the average rate of growth across the world is in percentage terms for their health systems globally at the moment? Now, it's slowed down, of course, because of the global financial crisis. But would anybody be kind enough, and I'm going to pick on 3 people, to guess what percentage is healthcare globally growing at the moment? And there's a prize of $100 that Amit Mukim from KPMG India, if you can find him, we'll give you later on. That was a joke, by the way. What percentage growth? So thank you, sir. So the first guess is 0. 1 or 2%? 5%. And your name is, madam? Sakita, okay. So we've had 0%, 1% and 5%. All very good answers. Yes, now, very good point. The actual percentage at the moment is about 2.9% growth globally. Of course, in some countries it's much higher, and in some countries it's much lower. Do you know what the forecast growth in India is for the next 5 years by independent and respected analysts? Should we play the game again, or do you just want to give me a number? 13%? 12%, can I have 1 more percentage points? You are a very, very clever lady indeed. The answer is 12%. Here's my point. So globally, healthcare is creaking at 3%, 2.9%. And in India, you have forecasts for the next 5 years, 12%. You can either carry on frittering your growth away, or you can collectively agree with the Indian Prime Minister tomorrow to do something differently about it. And I think that's what this conference is about. And the final thing I'd like to say is, if you want to know the answer, it's in this booklet here. KPMG, Necessity, the Mother of Innovation. Thank you very much indeed for listening to us. Do have a nice evening.